Well, guys, welcome to the East Tennessee Health Forum. It's January 27th. We've been at this now for a year. So this is actually our 5th meeting. We've had about 60 to 80 of us every 3 months coming together, enjoying community, dreaming of how do we help improve the health of our area in East Tennessee, where much of our health is very poor compared to other states in our country. And so, yeah, tonight we're looking forward to Dr. Wendy Warner out of Pennsylvania coming and sharing some of the latest updates on bioidentical hormone replacement, pros, cons, risks, benefits, and just having a place where you can bring things like that to the table and listen and be heard and see what can we do to help our patients best. Because sometimes in medicine, we get so pigeonholed into patterns of thinking and believing that we forget that there's always data to support any conclusion. So we need to figure out what's best for patients, what's healthy, what's healing. And we want this to be that area where people can bring any conversation up and we can look at it together. So we have that. We have a panel to discuss what are some ways we can help our women and men heal using hormone replacement therapy. Sometimes they need herbs, sometimes they need stress reduction, sometimes they need exercise. So it's not all just about hormones, but how do we bring their body into balance? So we have a full night, we have 5 lovely sponsors, and so glad you're joining us and enjoy the night. But I have some fun news first. Last Thursday and Friday, we had the Healthy Tennessee Summit. It was our first one we did. Several for people in this room was here. Actually, this whole table was there, essentially. These are my people who traveled all the way to Pigeon Forge. And it was absolutely beautiful. What we did was, we are partnering with the Blue Zone group, if you're familiar with them, out of California. And we're trying to bring them into Sullivan County, which is Kingsport and Bristol. And when I heard they were coming to town, I told Vicki over at HPI, I said, if they're coming all the way here from California, we should have a big shindig. And so, in 2 months, we put together the East Tennessee, or the Healthy Tennessee Summit. And it was absolutely fantastic. We had about 120 of us. We had farmers, we had teachers, we had doctors, we had CEOs, we had nonprofit leaders, we had school health administrators, we had Dr. Alvarado, the head state doc of Tennessee. We had this whole spectrum of people, and it was absolutely fantastic. We did film it all, so once that's done, I'll release it. But the Blue Zone folks were absolutely great. That's Dan Buettner Jr. Have y'all ever watched the docuseries? Yeah. That's his dad, and they're spitting images of each other. They look exactly the same. And this is my friend Lauren. He's 94 and a half, so he's the oldest one at the event. So yeah, Lauren's lovely. He's a doc, and he quit medicine when he was 50 to start discipling men full-time, and now he's 94. Just a lovely human being. And you can see how Dan and Danny look exactly the same. But, so we're trying to bring our businesses together to sponsor them to come out and do an area-wide assessment. But we had an absolutely great time. We had a lot of functional medicine friends. Paul Provance should be here in a minute. Patrick Hanaway came in, Monique, me and my wife, and then James. Y'all met James a year ago. He was here on our inaugural event. And then we had several panels during the event. That was absolutely great. Dr. Matuk is here. She's a local oncologist who is a lovely breath of fresh air. She's great. Yeah, so we just had panels. We had speakers. One of my favorite speakers was Joel, and he's a trip, y'all. He is a trip and a half. And if you ever have the Angel app, it's a group that produces documentaries and movies. They just released The Lunatic Farmer, if you want to watch that on Joel. And then this was an oldie but a goodie, if you ever watched Food Inc. So Joel's been around for a long time. But I tell you what, farmers just say it like it is, and they have no filter, and I love it. And so Joel was one of my favorite speakers, and you should go watch the movie when you get a minute. And that was us just hanging out, having dinner. Of course, we ordered hamburgers since we're with a farmer. And so, yeah, so the summit was great, and we're going to try to find ways, and I want to pull our health forum people in. You know, the idea is, how do we have a healthy Tennessee? So how do we have healthy school systems? How do we have healthy farmers and farms? How do we have healthy schools in general? How do we have healthy medical systems? Imagine that, medical systems that produce health. How do we bring these things together to really help our state that is ranked 48th out of 50? That's the issue. I've shared all those stats with you before. So I'll be getting y'all some information, and whenever we have videos from the Healthy Tennessee Summit, I'll launch that for you. So first, we have Jill, who is a friend, and she and her husband own Natural Foods. I send patients to them all the time. And so Jill is just going to share a little bit about their company, and I don't recommend walking in front of that line.
Okay. Hi, I'm Jill Bickford. My husband and I own National Foods Market. We're the second owners. We've been in business since 1981. We're just a little specialty grocery store, and we like to walk alongside the providers in the community to support healthy lifestyles. So one thing we did different this meeting is we set a QR code on our table. If you're a provider and want to be part of that network that we can refer out to you, just scan that QR code.
That's a great idea.
Information in there.
That's awesome.
Yeah.
Thanks, Jill.
Thank you.
Yeah, and make sure you go talk to Jill and all the other sponsors whenever we kind of break at the end. They're all fantastic. Next, we have Dr. Jinx. This is Beth, and she is one of the owners?
Yes.
Yeah, of Pro Compounding. Normally, Jess is here. Y'all have probably met Jess. There's Beth.
Hi, I'm Beth Jakes, owner and pharmacist at Pro Compounding Pharmacy here at Johnson City. And of course, we specialize in customized compounded medication. I became a pharmacist in 2008. My entire career is spent in compounding pharmacy with a particular interest in women's health. So we're happy to be here tonight to hopefully provide some insight into the world of compounded hormones and anything compounded that you want to know about. And so, thank you.
Yeah, you guys are great. And they're always so receptive. Like if you need something, you can call, send them a message, text them. I'll text Jessica. She always gets right back. I need to start texting you if I don't hear from Jess. And they compound literally anything you need, from pain creams to GLP-1s to all different meds. So they're absolutely great. So next we have Matt Walters. So he's our newest friends over from Quicksilver. I'm excited to hear what he's got because they got all kinds of cool products related to hormones and endocrine system. Yeah.
Wild stuff. My name is Matthew Walters. I'm with Quicksilver Scientific. I'm the Eastern Regional Manager as well as the Territory Manager of Tennessee, the Carolinas, and Virginia, so a pretty sizable chunk of dirt. Yeah, and so Quicksilver Scientific, we specialize in nanoliposomal delivery technology for nutraceutical agents, dietary supplements, as well as bioidentical hormone replacement therapy over the counter. We are also partnering with compounding labs to provide our nano-emulsion base for things like nanotestosterone. So really pushing the boundaries of functional and alternative medicine that are going beyond things of traditional or conventional dietary supplement companies. So, we were founded by Dr. Prichet, who has his PhD in environmental toxicology as well as aqueous solutions. So that's why 95% of our products are in that liposomal delivery. So thank you, Dr. Manfrey. This is a really exciting format and looking forward to the talk.
Yeah, of course. Always glad to have you.
Yep.
Thanks, Matt. And then we have Dr. Perry. I know who wants to speak. So Dr. Perry's an old friend. I worked for him in college. And I saw chiropractic, and I'm like, I want to do some of that. And that pushed me to go to osteopathic school. So
Yeah, it has been a blessing to know Dr. Mabry, of course, from the time he and I met. I don't even know when that was. But
07.
Yeah, 07, so it's been a while. And I had the good fortune of providing one of the first multidisciplinary clinics. We had medical doctors.
You have to hold it closer.
We had medical doctors along with a dentist that did TMJ, splint that's patented back in 1985, 84. So anyway, we have been in this area for since 1988, and we do chiropractic, physical therapy. We do nutritional counseling. We basically, where I had a good fortune to spend a lot of time with an MD that had a doctor of pharmacology too. It's been a good thing to be able to send people all over for whatever they need. So we definitely think outside the box, and it's really whatever the patient needs is what we provide. I appreciate Dr. Mabry inviting us to be here.
Yeah.
It's always good to see everybody. Thank you.
Yeah, my pleasure. And Dr. Perry and them do great with, they have some really lovely tables for lumbar decompression, cervical traction, and not everybody always carries those. So those feel great for people who need that. I was talking to Paul about that just a minute ago. And then last up, before we have Dr. Warner, I have Dan Toth. Dan's our newest friend over from Mountain View Pure Water and Air. So Dan's going to share with you.
Hey, thank you for having me here tonight.
Yeah, you're welcome.
This is the kind of group that I've always wanted to be part of. What I provide is a way to remove the toxins from our environment, water filtration and purification systems for in the home, so that you don't have to take in all of the chemicals and things like that that are not removed. And also we have air purification products, air filtration for allergies and things like that, as well as purification to remove toxic ESCs and things like that that can cause irritation. So I'm just trying to make it a safer environment for people who, especially those who are dealing with some sort of a medical issue and need to remove those toxins.
Yeah. Well, and you're coming by our house Thursday to check our water. So yeah. I was talking to a patient today, and sometimes the medical system's really bad about blaming others for their medical conditions, which is not kind or true, but we're swimming in such a toxic soup of chemicals around us in our food system, in our water, in our air. It's very hard to be healthy in America. Very, very hard. At the Healthy Tennessee Summit, I talked about it's kind of like fish swimming in a dirty fish tank. And they're yelling at the fish for being sick. Like, that's not kind or true. So I appreciate Dan being here to talk about how to help clean our water and our air. And so, did he already give you your little mic thing? Oh, good. So, what you all been waiting for, and I've been excited for, Dr. Wendy Warner, I got to meet her at the Institute of Functional Medicine conference out in Las Vegas last year, and we have a few mutual friends, and she's just a lovely human being and physician. I believe she graduated medical school in 1990, if my memory serves me correct, as a board-certified gynecologist. She was the president of the American Board of Integrative Holistic Medicine, an herbalist, and she taught much of the hormone classes when I went through my Institute of Functional Medicine training. So just a lovely wealth of knowledge, and she loves to teach, which is great. And so she has a wide breadth of experience, and I think she'll be really great just speaking to our crew. And then we'll have a panel at the end with 4 of our people. And so I don't know if you'd like taking questions in the middle or maybe save them to the end. But either way, we'll have her at the end on the panel. Please get some questions answered tonight. We're going to have a pharmacologist, a physical therapist, and 2 docs. So use the time to learn from them. So, Dr. Warner, come on up.
And he's making me younger than I actually am.
You're
I
welcome.
started medical practice in 1990.
Oh.
Not got in medical school.
You're welcome.
Is that on?
Her recording mic.
Is my recording mic on? Okay. Good. All right. Too much technology. All right.
I break.
So what I just told Michael tonight is that I actually grew up in Tennessee.
Sorry. I may have turned it off.
You did turn it off. Is that better?
Not yet.
No. There you go. I actually grew up in Tennessee. I grew up in Memphis. I came to Knoxville for undergraduate, went back to Memphis for medical school. I did apply to ETSU medical school. I would have been, I don't know, the 6th or 7th class, something like that. Got in Memphis sooner, so I just went back there. And then did residency up in Philadelphia. That's how come I'm not down here. And I always know I'm getting back to town because if you stop at a restaurant, you have to tell them non-sweet tea. I know, it's my favorite Southern joke. What can I say? All right, real quick, just so I know who I'm talking to. Who actually actively prescribes hormones? A whole bunch of people. Okay. Who either has a family member or personal interest in hormones because they are of a certain age? Okay, well, that's the rest of the group. All right, just so I know who I'm talking to. I'm going to hit the highlights. We could obviously talk about hormones for, I don't know, a couple of days. So we're going to hit the highlights. If you don't mind, save your questions for the end. And first, we're just going to talk about best practices. Bioidentical hormones have consistently been shown to be safer than non-bioidentical hormones. I mean, they've done meta-analyses 2 or 3 times in the past 20 years. Every single time, they've come down to that. Now, what I have to sometimes explain to my patients is that doesn't, no offense to the compounding pharmacist, that doesn't necessarily mean they have to be compounded because, you know, there are conventional bioidentical hormones. The only problem is the conventional bioidentical hormones are limited. Should we just use that word? Because there's only a couple of dosing, you know, like there's 2 doses for progesterone, you know, doesn't really individualize things. And then there's even minimal amounts of dosing differences in estradiol for women in conventional hormones. And there's no testosterone on the market in conventional form for women. So that's why I'm trying to think if I have any patients left over that use conventional hormones. I don't think so. I did conventional OBGYN for 14 years. And very early on, for personal reasons, I started learning how to do herbs and things because I had really wicked PMS. And nobody would have worked for me for more than about 3 months if I didn't get it under control. And I was trained that for those 3 or 4 days out of the month that I was a pain in the neck, I needed to take Prozac every day. So that's how I kind of ended up on this path. And after about 14 years of conventional practice, and helping my business partners through the Women's Health Initiative when they didn't know how to handle it, when all these people wanted to get off their hormones and I could offer them something, I ended up starting my own practice and haven't looked back. So, what they didn't teach me as a gynecologist is that it makes sense to test women's hormones before you actually come up with a prescription. Because they didn't teach us to do that. It was just sort of like everybody gets pretty much the same dose, and you never go back and test to see how they handled it. And that, even at the time, I'm going, well, that seems weird. So it makes sense to test, prescribe based on that, and then follow up with labs on a regular basis, because things will change over time, and you may be surprised that that individual person doesn't metabolize things the way you expect, et cetera, et cetera. Individualize for your patient. I was never taught in conventional practice to do that. Residency, just everybody got the same thing. And when I say individualize, it could be everything from maybe they need testosterone, maybe they don't. Maybe they need DHEA, maybe they don't. Maybe they do better with one form of compounded hormone than another. And then, of course, the labs you draw depend on the form of the hormone that you're giving. And for those of you who have not done any functional medicine training, in the hormone module where I teach, there's an hour or so long lecture just on testing and how to match it up with the right kind of hormones that you're giving. Because you don't want to use one form, use a test, base your dosing on that, and then find out later that you can't test. So like, for instance, topical progesterone cream can be really helpful. You cannot test it. There's not a single form of testing that makes any sense. Saliva, blood, urine, none of them are accurate for progesterone that's topical. So you just need to know that. Doesn't mean you can't use it. All right, when it comes to deciding on hormone replacement therapy, and this is basically how I explain it to my patients as well, there's sort of, I use this red light, the stoplight thing to try to figure out the candidate, because there are a few people that are absolute red lights for right now. If you have current unexplained vaginal bleeding, we need to just make sure it's okay. We don't want to go adding things in and then finding out later that we're, feeding a polyp or feeding endometrial cancer. If you're currently actively being treated for a hormonal cancer, probably not the best time to add hormone replacement therapy. I'm not so sure I'm going to say that in 15 or 20 years, just so you know. But as of right now, I have to say that. Now, the green light, I don't generally twist my patient's arm to do things. But if you're 35 years old and you are already menopausal, you need to go on hormones, and I will try to convince you to do that, because your chances of cardiovascular risk and cognitive decline and osteoporosis are so high from losing your estrogen at such a young age that I will hand you lots of data and convince you that you need to go on hormones unless you have some really good reason not to. Surgical menopause, as long as you have no other risk, same thing, because the chances of osteoporosis, cognitive decline, and cardiovascular disease in someone for whom we have removed working ovaries, it's not the same. It's much, much higher than someone who goes through the natural process of menopause. And then most people, as they go through natural menopause, as long as they don't have any other risk, they're actually, generally speaking, pretty good candidates. Now, there are a few people that are sort of in the iffy zone. Maybe a family history of a hormone-dependent cancer. Again, in 15 or 20 years, I may not be saying that. A personal distant history of a hormone-dependent cancer, meaning you had a breast tumor that had estrogen receptors, you're more than 5 years out from your diagnosis, you're doing great. Yellow light doesn't mean that you can't go on it, but you might want to look at all the risks. Really big fibroids, well, any fibroids. It's a relative risk. You can make those suckers grow. And honestly, it's not so much the estrogen in the prescription, I think it's the DHEA. We can talk about that if you guys have questions. I have actually made people's fibroids grow inadvertently. And it's problematic when that happens. And then if you're more than 10 years past your final period, it's not, I'm going to go into this in just a second. Once upon a time that was contraindicated, and now it's still a little bit controversial, but I'm going to go through the data about why I am perfectly happy starting people on it. They need to understand the risk and benefits. So they go into the yellow light category now. And just so you guys know, that's not the way I teach it at IFM, because they're still a little bit conservative. Okay, how late is too late? I'm going to just assume you guys know a good bit about hormones. I want to go into some of the controversies first, and we can always backtrack to some of the basics, because I want you to hear about the potential controversies and why I have feelings that I do. Now, prior to the Women's Health Initiative study, which came out in 2002, and some of us in the room were in practice at the time, what you guys have to understand about that, it hadn't even been published yet. They stopped the research and did a press release. So our patients heard it on the news. We were busy at the office. The phones start ringing. We don't even know what the heck they're talking about. So we had to go find out about the press release. Anyway, prior to that, women were put on hormones and pretty much left alone forever. I mean, they went to their grave on hormones. And they were either doing injectable estrogens, most of it was Premarin and Provera. Sometimes there was this methyl testosterone ethinyl estradiol combination, which was kind of interesting. Now, once the Women's Health Initiative study came out, and we'll talk about the details of that one in a second, it scared the bejesus out of everybody. And so everybody said, smallest dose of hormones possible just to treat symptoms for the shortest amount of time possible, and then get them off, because it's going to cause problems. Well, you guys have probably heard, because a lot of people are in the media now talking about the Women's Health Initiative study, but what that study was originally designed to do was to prove that you could put women on hormones and it will help protect them against heart disease. That's what they were trying to prove. The problem was, the study participants went anywhere from 45 to like 80. And they were on either Premarin or Provera, depending on whether or not they had had a hysterectomy. If they'd had a hysterectomy, no Provera. Notice, Premarin, it's only bioidentical if you're a horse. Provera is a nasty drug that I don't think needs to be on the market anymore, because we have seen so much trouble with it. And when you look at what got reported was, oh my God, it's 5 years and people are getting an increased chance of breast cancer, we have to stop the study. Okay, what actually the study showed is that there was a very small, barely significant increased risk of breast cancer if you were on the combination of Premarin and Provera. And oh, by the way, if you were taking Premarin alone, your relative risk was less than 1, meaning it actually helped protect you. Not that I want to use Premarin, but isn't that interesting? So clearly, as soon as I looked at that paper, I went, guys, it's clearly the Provera. Why is this so complicated? You know? Anyway, so the Premarin in the Women's Health Initiative study actually was not the cause of breast cancer, but it made everybody nervous. Now, the problem also, when they forgot about the breast cancer stuff and they looked at the rest of the study, They did find that if you use oral estrogen and a fake progesterone in a woman who's well past her last period, yeah, a lot of those people were having increased incidence of cardiovascular disease. But look at what we were using, a fake progesterone and oral estrogen. So that's what actually caused the heart disease. You have to be very careful how you talk about hormones when it comes to the research. Okay, fast forward a little bit. People were starting to use some truly bioidentical hormones. Someone finally figured out how to make an oral progesterone that made it through the GI tract. And we started doing studies, and they started coming up with what is now called the timing hypothesis. It became very clear that if you start hormone replacement therapy within, now this is according to the timing hypothesis, within the first 5 years of your final period, you're going to get a great deal of cardiac benefit. Beyond the 5 years, less so. And they didn't even look past 10 years. And then studies were also done on cognitive benefit. Same sort of thing. You'll get your most benefit if you start hormones in the first 5 years. So we kind of went with that for a long time, but we still didn't know when to stop people. There was some indication that maybe we should think about stopping after 10 years, but that wasn't really based on a good study. And for those of you that have patients on hormones that are really happy, isn't it horrible to have that conversation of, gosh, you've been on like 10 or 12 years, we need to start thinking about weaning you off. And I have patients that go, over my dead body, because they're perfectly comfortable. And fortunately, lately, and I'll show you a study about why I do this now, I was in the middle of weaning people down, and just in the past year or two, I've been able to say to them, guess what? We get to stop weaning off. You get to stay on it as long as you like. Now they like me again. All right. There was this whole conversation about don't start anybody after the age of 60 or if it's been more than 10 years since their final period. Now the data is getting more clear. So now, this was a paper just from last year looking at if you start within 10 years of your final period or younger than age 60 versus more than 10 years or older, or 60 and older. If you're in the first group, it's going to be safe for pretty much everybody. You get a reduced all-cause mortality. Now let that sink in a minute. From everything that could possibly kill you, you're better off. And when that paper first came out, we looked at each other and went, wait a second. They're talking a lot about, like, still people on oral estrogen. I mean, we know that causes strokes. How could it be all-cause mortality be better? Is it just that they go to the doctor and people are watching them? And I pulled the paper, and I actually looked at the research and went, well, dang, that's better than expected. All right. Definitely reduced cardiovascular disease, stroke risk, and venous thromboembolic diseases are only a problem if you use oral estrogen, and the increased risk is relatively small. So basically, don't start anybody on oral estrogen unless you have a really good reason to. Now that's in the younger age group. If you're starting more than 10 years or you're older, it doesn't really affect your all-cause mortality either way. You don't get the benefit, but it doesn't mean like it's going to make you die. You don't really get an effect on the cardiovascular disease at that point because theoretically you've had 10 years or more where you've lost the benefit from the estrogen. And so there's already damage done. But it's not going to make it worse. You're just not going to get the benefit. And then you do have a slightly higher stroke risk, but again, that's only with oral estrogen. So even if you want to start older people or on hormones, it's perfectly acceptable. Now, I want to point out to you what's happened to this, what I refer to as this lost generation of women. Imagine, you're an OBGYN resident. It's 2002. The Women's Health Initiative study just came out. Your only tool to help a woman with menopause is hormone replacement therapy, and you were just told it's bad. So what happens? You go out into practice just telling people, suck it up. And there's a whole generation of docs like that. They don't even engage patients in this conversation, which I find Horrifying. I also kind of don't blame them because that's what they got taught, right? So those are the women that are making all the noise now on social media, going, wait, what about us? And I've got these women who are calling me going, haven't had a period in like 8 years. Can we have this conversation? So, sure. All right. The study that I was just describing, the way they came up with this data, it was based on Medicare drug prescription records, plus encounter records. So when I see that it was based on just the prescriptions, I mean, did they really take it? I don't know. So maybe the data isn't as clean as I would have liked, but it's decent data. They were comparing lots of different forms and schedules of hormone therapy. And overall, from that data, the risk was a lot higher for fake progesterone versus real progesterone, oral estrogen versus either topical or vaginal. Those are the only other two forms. Nobody in the study was using pellets. That was not part of the study. And nobody was using any buccal troches. Higher dose versus lower dose had a slightly higher risk. And conjugated equine estrogens had a higher risk versus estradiol. Kind of makes sense because it's not our estrogen. Okay, how about breast cancer? Well, the Women's Health Initiative study, like we talked about, said, oh, this is such a problem. The EPIC study, which came out later, actually showed that estradiol alone did not increase the risk for breast cancer at all. And estradiol with bioidentical progesterone had a relative risk of 0.9. So for those of you that don't know statistics, relative risk of anything less than 1 actually means it's good for you. It was safer. And then estradiol with a progestin, a fake progesterone, the relative risk was higher, but not horrible, 1.4. It's not like it's 10. And one thing I'm just going to make a comment about, because I talk about this all the time. If you're looking at research on hormones, you will end up wanting to tear your hair out because the terminology gets thrown around all the time. They'll say progesterone in the study title and maybe even in the abstract, but then when you get to the materials and methods, they actually used a progestin. And it's like, so if you're reading hormone literature, please read every single word. I know nobody does that. You read the abstract, you jump to the conclusions, but you have to because they're not good about being clear what they actually used. Okay, here's the other interesting thing. We know that if you are unfortunate enough to develop a breast cancer while you're taking hormone replacement therapy, especially combined estradiol and real progesterone, it's typically well differentiated, slow growing, less aggressive, easier to treat. So this is the question I'm wondering these days. So if that is true, and we also know that breast cancer may not be the causative agent, why are we spending so much time and energy for women who've gone through breast cancer treatment trying to make sure they never have another molecule of estrogen? I'm really not sure what to do with that, and I'm really glad I'm not an oncologist because I think they're going to have to rethink what they do and go back and actually look at the literature. And again, I'm not so sure in 10 or 15 years we're going to be worrying so much about aromatase inhibitors and that sort of thing. Okay, menopausal hormone and cardiovascular risk. Lower estrogen concentrations are associated with high levels of inflammatory cytokines like IL-1, IL-6, and increased TNF-alpha production in T cells. Progesterone, real progesterone, acts on its receptors that are located in the vascular endothelial and smooth muscle to promote cardiovascular effects similar to estrogen. Progestins, fake progesterone, don't do this. This is another reason why, even if the woman's had a hysterectomy, please put her on progesterone along with the estrogen. Every gynecologist to this day gets trained. If she doesn't have a uterus, she doesn't need a progesterone because, it's only there to protect her from getting uterine cancer because the estrogen will do that if you don't block it. But we have progesterone receptors all over our bodies, and we know that progesterone is going to help decrease her cardiovascular risk, so please make sure you include it in your prescription. We also know that progesterone increases enos, which is going to improve nitric oxide bioavailability and downstream vasodilation. So it's going to help her heart as well as estrogen does. Neither of those things happen with synthetic progesterone. And this is interesting as well. If you have, make sure you ask your patients about their pregnancies, if they've had any, because adverse pregnancy outcomes actually are related to their risk of heart disease later in life. So preterm labor, gestational diabetes, hypertensive disorders, preeclampsia, eclampsia, those are all important things to ask their patients about, because those women are all at increased risk for getting heart disease later in life, and hormones will positively impact that, help them protect against that. Also, any systemic inflammatory disorder, basically autoimmune conditions, you have a 2 to 3-fold higher risk of MI out of proportion to other traditional risk factors. So ask your patients about autoimmunity and family history of autoimmunity, because autoimmune conditions, if it didn't show up at puberty and it didn't show up after a pregnancy, it might show up at perimenopause. And if their family members had autoimmune conditions of any kind, your patient is at increased risk. Breastfeeding decreases cardiovascular risk later in life. So congratulations to anybody who did that. And again, it's another thing to ask your patients about. And you know, a brand new mom is not thinking about having a heart attack when she's 70, but it's another thing you could tell her. And this is, I think, really fascinating to me, because I was told, oh, you know, there's problem calcifications on mammograms and then there are ones you don't worry about. Well, it turns out that even the benign calcifications on a mammogram are associated with increased risk of heart disease later in life. So why is that true? Well, we lay down calcium in any area that is inflamed, which means this individual woman has more inflammation. It might be from autoimmune conditions, it might be from diet, it might be from who knows what, but that increases her risk later in life. So be sure to ask all these questions. All right, menopause symptoms, basics, because I was trained that it's all about dropping estrogen levels. Now, I'm going to tell you 2 quick stories about patients that I ran into, and it relates to the slides I'm about to show you. When I was a resident, I don't know, 2nd or 3rd year resident, I'm in clinic, and this 35-year-old woman comes in, really smart. I was very surprised, very impressed. She goes, "Doc, I haven't missed a single period, but I'm having night sweats, and it's making me crazy. I've already figured it out. It only happens the week before my period." Now, I trained in a very bad part of town in Philadelphia. She was totally stressed out. Baby's father got thrown in jail for something he didn't do, so she was going to lose her apartment because she needed to help him pay the rent, you know, him to help pay the rent, all this stuff going on. And I'm thinking, wait, 35 years old, having night sweats, huh? I go out and I tell my attending, because I don't know what to do. And he goes into this whole long spiel about, well, you know, that's the part of the cycle where the estrogen is dropping, and so dropping estrogen causes hot flashes. I'm letting him talk. I said, "Sir, she's 35. She hasn't missed a single period. I don't know any other 35-year-olds having hot flashes." And I don't remember what he told me to do. I'm sure he told me put her on the pill. But I kind of filed it away going, well, that's weird. And then, of course, I had to keep moving because you're in residency, you got to answer questions a certain way. All right, fast forward a few years. I'm now a brand new doc in practice. I don't know. I'm 32 years old. What do I know about menopause? I will always remember this person. 69 years old, a little heavy, walks in as a new patient and says, "Hey, doc, is it possible to do menopause more than once?" I went, "What?" She goes, "Well, had my last period around 50, had a few hot flashes. They weren't all that bad. So I never took any hormones. They went away. I've been good all this time. But now they're back, and they're making me crazy. I'm having hot flashes a lot during the day and then early in the evening." And I'm thinking, well, this doesn't sound like any menopause I've ever heard. So what do we do when we need to buy some time? I sent her off to get labs, hoping to have enough time to look this up, right? She comes back. She's diabetic. I went, oh. So I sent her back to her family doc. When they got her blood sugars under control, her hot flashes went away. And I'm thinking, well, that's weird. That's two things that have nothing to do with estrogen. And, you know, years later, I actually understood it. So just keep those two stories in mind. This paper is all about cortisol dysregulation and reported hot flashes among this group of women. And this is a fairly old paper, actually, from 2016. And the more frequent, severe, and bothersome the hot flashes were associated with the higher cortisol levels. And the higher hot flash frequency was associated with something called the cortisol awakening response. Basically, how much does your cortisol change from the minute you open your eyes for the next 30 minutes? It's supposed to go up, like to wake you up and get you going. And those with the greater hot flashes in general tended to have the highest bedtime cortisol. And here's a diagram from that paper. The blue, now for those of you that know what a salivary cortisol level is supposed to look like, it's pretty much that blue line. You know, you start off, you go up, you peak by about 9 in the morning, you drop off until about 12, you sort of fatten out, and it should be low enough at night you can fall asleep. All right, so these have the blue line is the least number of hot flashes. The red line, they were sort of in between. Notice they're starting off with a cortisol that's lower, but they still have that nice big rise. But then for the rest of the day, they're higher than the folks who had the fewer hot flashes. Now, look at the poor folks in the green line. They don't have any rise in their cortisol in the morning. Their cortisol awakening response is flat. That implies they have very little adrenal reserve left. Okay, that's not good news. And they stayed the highest the rest of the day, and they're really high at night, which means they're going to have trouble falling asleep. So cortisol dysregulation, hot flashes, they go together. All right, some brain chemistry. There's no test at the end, so if your eyes glaze over, I won't be offended, because this gets down to the nitty-gritty. There's a place in our brain called the thermoregulatory center, and it is, the way I describe it to my patients is, think of it as a switching station, getting lots of information. Some of the chemicals involved are kisspeptin, neurokinin B, and dynorphin, and these control the secretion of our gonadotropins, which then control the secretion of our ovarian hormones. And basically, if everybody's happy, you're going to be getting, if the dynorphin and the neurokinin B are talking to each other correctly, you're going to get appropriate balance of hormones. And if you get a loss of that function, it's going to be problematic. And this is just, if you like diagrams, this just tells you how everything is connected. And one of the things that they have learned is that estrogen is basically giving this negative feedback by suppressing the kisspeptin and neurokinin B release. And that then reduces the GnRH neurons. And when you lose your estrogen, the whole system goes haywire. And remember there, a year or so ago when, I'm blanking on the name of the drug, Veoza? When Veoza came out? It was supposed to be this wonderful new non-hormonal drug for hot flashes. It works on this pathway. And here's what we always like to say in functional medicine. Thank God for pharmaceutical companies, because they have enough money to figure out the biochemistry, and then we can just work backwards to figure out how to address the same thing without giving people a whole bunch of side effects. Because Veoza works on this to basically take the place of estrogen to keep the balance, and so you don't end up with these triggering of hot flashes. But the problem is there's now a black box warning because it gives you liver failure. You're supposed to, before you start someone on Veoza, you have to get their LFTs, and then you get them every quarter for a year. And I'll tell you this quick story. When it first came out, I was on social media with a little video explaining how it works because I'm really kind of glad they figured out this system. And I made a comment about, well, I don't really know. I mean, it works really well. People in the studies were very happy with how well it got rid of their hot flashes. But the safety data was really kind of questionable. And I just put it out there and forgot about the video. A week or so later, I get an email from the people who make Veoza. Gosh, Dr. Warner, thank you so much. We saw your video, and you did a great job of explaining how the drug works, but it sounds like you have some questions. Would you like to talk to one of our pharmacists? I went, yes. So I got on the phone, and I didn't get any of my questions answered. Because I said, now, why am I checking liver enzymes? I mean, you know, some of these people, and she said, well, you know, in some individuals, their liver enzymes go up, but if you stop it or you lower the dose, they'll go back down. I went, okay. How come I only have to do it for the first year? Well, that's how long the study was. Okay. So when liver enzymes go up, you do realize there's a lot of liver damage. Did anybody go in and like look for fibrosis or anything? Well, that wasn't part of the study. So I really, oh, and by the way, if you have to pay cash for Veoza, it's $3,000 a month or something like that. Yeah, for hot flashes. Okay. And the black box warning actually just came out in the past couple of months because a woman did not have her liver disease reverse when she stopped her drug. And she ended up dying from liver disease. Okay. So we talked about cortisol causing hot flashes. Now we're going to talk about glucose causing hot flashes. In the SWAN study, which is an older study, they keep going back and looking at the data. It's all on midlife women. Turns out that hot flashes were associated with a higher HOMA index, which is basically looking at your blood sugar and insulin regulation. To a lesser extent, it was associated with having a higher glucose in general, but it had more to do with your insulin. And this didn't make any difference, you know, based on your estrogen status, your BMI, anything. And that, nobody talked about that when the SWAN study first came out, which I thought was really interesting. So basically, glucose and insulin are a problem. Just remember my 69-year-old patient who was having menopause for the second time because of diabetes. Okay, estrogen and brain inflammation. You know how, for any of us who've been through this, you know how you can't think straight when you hit perimenopause? It's real. Everybody who's never been there personally, it is real. And basically, this is a diagram of all the things that estrogen does for our brains. And just look at this whole section on neuroinflammation. It drops all these inflammatory chemicals in your brain. And so obviously, when you lose your estrogen, all those things go up. And if your brain's inflamed, you can't think clearly. So we're going to talk a bit about how menopause is less, I mean, the hormones are important, but it's really more of a neurologic transition rather than just a hormonal transition. Because the things that go haywire in perimenopause have to do really with your brain. Your sleep regulation, your temperature regulation, your circadian rhythms, your sensory processing, everything. So the estrogen receptor network in your brain is basically getting uncoupled from the cell's ability to use estrogen. So this is a little diagram that I made of where all the alpha and beta estrogen receptors are in the brain and what they do. And if you look at what they do, it's all the crap that goes wrong at perimenopause. You can't think clearly, your emotions are less stable, you can't sleep correctly, all of that. And so your brain is literally rewiring itself. So when women say to you, I really don't feel like myself, there's a reason. Because think about it, if you need the estrogen for the cells to use glucose for fuel, and the cells suddenly realize that the estrogen is less reliable, they start going, oh, we got to go do something else. So they just start getting uncoupled from the estrogen receptors and they go looking for another source of fuel. We think it's ketone bodies, they're still working on that. And what will happen if you don't go on hormone replacement therapy, talk to any woman who's went through the change, never took hormones. This is what she'll tell you. I had a couple of years where I was crazy. And then gradually I realized I was myself again. And that's pretty much what happens in all the studies. They look and they say, you got about 4, 5, 6 years of transition where your brain is going haywire. They're actually doing PET scans of changes in women's brains at perimenopause. And then it all kind of settles down for most people. Now, there's still some women who never get their brains back. But most of us, you know, if we have memory loss at that point, it's no worse than our male friends at our same age. Doesn't mean we want our patients to be uncomfortable for 4 to 6 years. That's not what I'm trying to say. But it's just describing what the natural process is. Okay. This is a really ordered and sequential process, and basically you're just disengaging. I've already talked about all that. All right, immune function. This is the other thing you need to warn your patients about. Our immune systems go haywire at perimenopause, and I love this diagram because these are different markers of immune function, and you'll notice that basically your baseline over here in premenopause is low. It kind of goes haywire in perimenopause, and when it settles back down in menopause, look how much higher it is. So basically, what this comes down to clinically is women will develop autoimmune conditions they never had before. They'll develop contact dermatitis they never had before. That happened to me and really pissed me off. I am now allergic to poison ivy. I'm one of 6, and I was the kid that when we were young, some of my siblings were really highly allergic, and if the ball went into the poison ivy patch, I could go get it. Not a problem. Perimenopause? Now I can't do Virginia creeper or poison ivy. It really pissed me off. So let women know that that can be a problem. And that's why women will get these weird rashes out of nowhere. They'll get autoimmune conditions, all of that. It's all about our immune function changing. That's the inflammatory thing that's going on in their brain as well. Now, basically, if you think about it, what I'm saying is you've got this whole, if you're getting this inflammatory stuff going on from your immune system, you're going to be affecting your brain, so that'll affect your cognition, it'll affect your heart, and all of that can be modulated by hormone therapy. So this is basically my summary slide. Hormones are more appropriate for more women than we once thought about. The form, the type, and the dose is important. This is not a workshop on how to write prescriptions for hormones, sorry. Bioidentical is always safer. The total time on hormone is based on your individual patient. There is no rush to stop. And remember that, here's what I say to all my patients. There's lots of good reasons to be on hormones. You're gonna feel better. Don't forget to fix the cortisol. Don't forget to fix the blood sugar, because you're not gonna think about it as soon as you stop having hot flashes. Well, you might, I actually still have patients whose cortisol is so bad, they still wake up. They just don't wake up hot. And they still would be packing on the pounds because they never fixed the cortisol and the insulin. So you have to look at the whole picture, but I've got lots more people in my practice on hormones than I did even 10 years ago. All right, thanks for your attention. Questions?
So, not all hands up at once, but Jim.
So, my lovely bride couldn't make it tonight, but she will kill me if you can't tell me how to fix her brain. So can you just use more estrogen? Can you just run the estrogen up really high and help that? Because she has a lot of brain fog.
Is she already?
It's okay with me saying it.
Is she already on hormones?
Yeah.
Okay. If she's already on hormones, don't just rev up her estrogen. You'll make her so PMSy.
Okay.
She will hate you. Look into inflammation.
Okay.
Look at cortisol, look at blood sugar. I'm thinking it's probably that.
Okay.
Does she sleep okay now?
Yeah, progesterone 200 milligrams a night. She sleeps all right.
Okay. Yeah, so if she still has a lot of brain fog, I would look at inflammatory markers and glucose, yeah. Because if you just run it, that's one thing. If people still don't feel perfect, don't just automatically assume they need to add more estrogen, and don't assume that if they're having hot flashes and they've only missed 2 periods that it's time to add estrogen. You might just make them bleed heavy and give them bad cramps and breast pain, and their partners will hate you because she's being really PMSy.
Well, there's other reasons for foggy brain.
There are lots of other reasons. Yeah.
I show a lot of my women this photo. It's the woman's brain before and after menopause. And I tell them, it looks like the lights are off. And they say that's exactly how I feel.
Yeah, so if you don't know Dr. Lisa Mosconi, she's a PhD researcher in New York, one of the schools in New York. That's probably one of her scans, because her studies are on PET scans of perimenopausal women. And they're scary because the lights do go off. All right, next question.
What's your opinion on the Dutch hormone testing compared to the blood testing?
Okay, so questions on Dutch testing, which is a spot urine test. It depends on what you're looking for. I know the owner of Dutch really well, and for the longest time he got pissed at me because I would talk about his test all the time, but I never ordered it. He goes, Wendy, why don't you ever order my test? I said, because it's so expensive. Because it is crazy expensive. However, it is very accurate. And one of the things that I will give that company a lot of credit for is that they are trying to make sure that they are giving you good data. And they're trying to get published data on like using it to follow hormone replacement therapy dosing. Because originally they only had data to show that they could tell you where you are, but if you were taking hormones, it wasn't clear. And now they have studies on, you can track topical estrogens with their test, and you can track progesterone with their test if you're taking oral progesterone.
Well, it's so much more detail.
Yeah, and here's the piece that I love, because I'm too close. Whoa, it's gonna bite me. This whole section on the bottom right, this is estrogen metabolism. We're really smart, just not techie. This whole estrogen metabolism piece is super helpful because, and the methylation down in the bottom left, the COMT pathway. Okay, so sometimes you put people on what you assume is going to be a perfectly good prescription, and maybe she's getting breast pain that's lasting longer than she expected, or she gets some bleeding that you wouldn't have expected, or something kind of estrogen dominant looking. I will often run one of these tests to see like what's with your metabolism, because if she's not getting rid of the estrogen effectively, basically she's getting like a double dose. So if any of these pathways are slow, or if you get down to the bottom, and that first piece is phase 1. Phase 2 is about methylation. Many of us don't methylate well. So then you still won't be getting rid of your phase 1 estrogen breakdown products, and they're still very active. That's easy to fix. You just help her methylate with diet and supplements. And this one here, the 4 pathway, the red line, you don't want people going down that path because that causes cancer, DNA damaging chemicals. So you can block that pathway. I usually there's a herbal product that has hops in it that is a really good blocker for this, and no, you can't just drink a beer and get the same thing. I've had patients ask. Yeah, I've had patients ask. Yeah, so the Dutch test is really helpful. For my patients who don't have the finances to be able to do it very often, because it is pretty expensive, for most of the forms that I use for hormones, you can get just regular serum levels. You do have to, like a serum progesterone level is not all that accurate, even if it's oral, but it gives you a rough idea. Yeah. Next.
Could you help me understand the relationship between HRT and autoimmunity?
Okay. Question for those who might not have heard it. The relationship of HRT and autoimmunity. It's such a long answer. If you have a predisposition to have an autoimmune condition, it's likely going to flare during perimenopause. If you can help balance hormones, estrogen and progesterone and all of the ovarian hormones, that's going to slow the autoimmune process down. So if you start people on, if you say you already know that she's got an autoimmune condition and you're trying to keep her from having a flare and she's starting to get symptoms, might be a reasonable thing to put her on hormones, along with lowering inflammation, not eating gluten, looking for heavy metals, all those other things that could be problematic. Now, that being said, I do have to tell some of my patients, if you've got an autoimmune condition and I've got you on hormones, we have to be super careful to keep your hormones balanced. Because I've had, you know how you have the patient who's not real good at remembering every single dose of whatever you ask them to take, and so when it's hormones, they're bouncing all over the place. I've had people get themselves into an autoimmune flare just because they weren't taking their hormones consistently. So it can kind of go both ways. Yeah, somebody over here.
Can you give some advice on when herbs would be appropriate with, like, for the people that are not able to take HRT? Is it appropriate to use herbs? And what would be some good sources if that is our scope of practice?
Okay, herbs, thank you. All right, I like talking about herbs. I will often start people on herbals if they're, okay, classic person, now that everybody's talking about perimenopause. 42-year-old woman hasn't missed a single period, having some hot flashes. Her periods are a little different. She just hasn't skipped any. A little more PMS than usual, and she's not sleeping, and she only flashes for part of the month. That's a person who would do better with herbs than hormones, at least to start, because she probably doesn't even need the hormones. She's doing a fine job making hormones, they're just not balanced. And so if you can help her balance her own hormones, why would we need to add anything else in? That's the person who probably needs to look at their blood sugar and their cortisol and that sort of stuff. Now, I'm very, very, very picky about where I get herbs because it's so easy to screw them up. There is, I'm so glad this isn't CME, I can say whatever I want. There's a really nice product that Metagenics makes called Aloe Vera. It is Siberian rhubarb extract. We know that this extract sits on beta estrogen receptors, and it works really well for hot flashes. It works better if you add in herbal adaptogens. You help her kind of calm down her adrenals, but it works super well. I also get a lot of herbs from, and I have to tell you, I teach for this guy. I get a lot of herbs from a company called Herbalist and Alchemist. The owner is David Winston. He's my boss. I teach for him. Mountain Rose Herbs. This is an awesome place. They have some medicinal herbs. I get more of my bulk herbs and essential oils from them, but that would be a good place to start. And a shameless plug, if you want to learn everything you need to know about herbal medicine, David Winston Center for Herbal Studies is a great place.
Let's do Kim, and then we'll do the panel.
Yeah.
I'm wondering if you've noticed a relationship between women going through menopause and joint pain. I get a lot of commercials on my social media feed, but I haven't really heard anyone talking about it.
Yes. Question was about joint pain and perimenopause. Very, very common to have joint pain for the first time ever as a menopausal woman because estrogen helps with our synovial fluid production, and lack of estrogen in the joints can be very painful, which is also a common side effect of the aromatase inhibitors that you give somebody when they've had estrogen-positive breast cancer. Women will be able to put up with the hot flashes, they just can't put up with the joint pain. So it's all about inflammation. So for someone like that, either it should get better if she chooses to go on hormones. If she's not going to opt for hormones, you would think inflammation and then anything that will help with a little bit of estrogen, like the Aloe Vera that I just mentioned. But mostly, high-dose fish oil, SPMs, and an anti-inflammatory diet, and move those joints, because the more they move, because it hurts, so they stop moving, and that makes things worse.
You get my wife next, so I'm not in trouble.
Okay.
Now the last one.
Now the last one. Nice to know the boss.
Yes,
Can you go back to the 35-year-old patient who was having the hot flashes, like right before her period? What was the main cause for her having those?
She was stressed.
Adrenals.
It was all adrenals. It was all adrenals. She lives in a bad part of Philly. Her partner had just gotten thrown in jail, and she didn't have his income, so she was about to lose her apartment. I didn't say her youngest was getting hassled by the drug kings on the street corner, and her older kid was getting hit on by the hookers on the corner.
A lot of stress.
A lot of stress.
One would say.
One would say, yeah. All right.
So, we have our panel.
Are we going to pass this?
How
are we gonna do it?
Pass it. Like, I know you're making the compounding. You guys are making, docs are prescribing it, providers are prescribing it, and you're talking to the patients and you're helping them navigate dosing and all those things. What are you finding helps patients the most as they're on their hormone journey?
Yeah, absolutely. I spend probably the majority of my time with the patient, just going over basic hormone education, because most of them have never heard it before. It's all new. Their bodies are changing, their lives are changing. It's affecting their relationships, and we take that very seriously. And so for them, it's just having somebody that they can talk to for more than 10, 15 minutes, to kind of navigate, the symptoms that they make sense, and then trying to help. Oftentimes I find myself in between the practitioner and the patient, which is sometimes a hard place to be, I won't lie. But we do, try really hard to navigate helping a practitioner figure out how to help the patient, and helping the patient figure out how to communicate with the practitioner. And so it is a very kind of delicate place that we have to navigate. But I would say 99% of the time we find ourselves educated.
Can I make one comment? Please. When I first got on my journey of learning how to prescribe compounded hormones, because it was totally new to me, I met a wonderful compounding pharmacist who happens to be several states away from me, and talked to her, listened to some of, she lectured back in the American Holistic Medical Association meeting days. This is how long ago it was. That organization doesn't even exist. And I literally had her mentor me. I would say, okay, I'd call her up and go, here's my patient, here's her symptoms, here's her labs, this is the prescription I wanted to do, tell me how far off I am. And within, a couple of months, I kind of had the swing of it. Now, as of right now, well, for a long time, I don't prescribe as high a dose as she does, because she's not the one getting the phone calls with the breast tenderness.
Yeah, sure. Yeah. And Noelle, you want to introduce yourself, and then explain like how you and your crew walk with women through a lot of these changes.
I am Noelle Eads. I am co-owner of Impassion Public Health with Melanie Abbott. And so we specialize in pelvic floor therapy. We treat women, men, and children, but about 75% of our population is women. And we are a very holistic practice. And so we really do work a lot with pro-compounding and providers in the area that are very open to hormone assessment and intervention. And I would just say, for us, one of the biggest things in this area is really appreciating providers that are willing to treat these patients and look at the whole picture with them. For us, one of the biggest things is it really is a whole body experience when we treat women dealing with these issues. And so they may have incontinence or pelvic pain, but underneath muscular dysfunction and a lot of the things we treat is a lot of inflammation, high stress levels, adrenal dysregulation, things like that. And so what we do is everything we can kind of conservatively on our end to really help patients, guide them and manage the lifestyle aspects while treating the physical. But there is a point when if they can get that extra help from a hormonal standpoint, we just see huge differences in tissue health and food and stress, all of it. And so it's a big connector.
Well, I would imagine too, in pelvic floor, you see a lot of like vaginal issues, dryness, pain.
Yeah.
How do you see patients do, like with the topical creams?
When they are prescribed correctly. I would say when it's the right compound and the right thing for them. And I would say one of the other big things too, we really try to help patients. There's a lot of fear in this region still with hormones, estrogen, things like that. And so being able to help them. And one of the things for us that I think we see as a benefit compared to some other providers is we often are seeing these patients weekly. And we see them for an hour one-on-one. And so just to be able to talk to them and work with them and then actually help them assess their tissues, show them that improvement, let them see it on a weekly basis, it's a lot of times a lot easier for them to buy into it, which is really great.
Yeah, I think so too. And Dr. Martin, would you mind to just introduce yourself and how you're helping many, many women in our region just have balance?
Yeah, I kind of have a similar journey, Dr. Warren. I think I've been in practice about 28 years and prescribing hormones the entire time. Similar journey with the WHI. I can remember patients coming to see me clutching Suzanne Simon for 6 years and saying, help me, I've been taking off my hormones. I was young enough to still want to try. And I'm probably about 3,000 patients on a bioidentical type of hormone. Our approach is holistic in general, but it's still traditional, traditional GYN methods. So, nothing magic about that part, but.
Well, and let's say maybe a question for you and Wendy. Let's say you're a provider and you don't have much experience with hormones. How might you start educating yourself? Books, classes, group, organizations, how might you encourage them? Because there's a lot of OBs in our area that do not do much hormone use.
Yeah, the statistic I think I saw, up to 80%, probably more, of women will have menopausal symptoms helping meet therapy, and only 2 to 4% get out. So
It's crazy.
It's overwhelming. I think you gotta go outside of the traditional teaching methods right now. So it's like functional medicine. There's A4M. There are specialists in hormone therapy. I think it probably is going to be reintroduced into traditional medicine because there's too strong of a cause for it. But I don't think we're as afraid of hormones anymore. We've got an oncologist here that's amazing. So, but yeah, that's where I'd stand.
Sure. Yeah, you're so much more optimistic than me. I would love to think that they're going to get back to actually teaching this, at least in GYN residencies, even if they don't teach it in med school. But yeah, conventional medical training is roughly 40 to 50 years behind the times. And so I don't know what it'll take to get into conventional training. But yeah, and if you want to know more about it yourself, the Institute for Functional Medicine has a basic course plus a whole 2.5-day module on hormones. A4M has trainings. There are a couple of other people who do trainings on hormones. Or you can just hook up with a local compounding pharmacist and go, okay, I heard them talk about it. I don't know anything. Tell me something. And you can figure your way through this.
And
don't be nervous.
And what might you two say for non-medical people who are just interested in hormones? Any books, any podcasts, any sources for them just to become more knowledgeable? Because I find patients drive a lot of the change in our culture. When patients are beating on the door, like, I want to know nutrition, doctors start learning nutrition. Same for hormones. What are some sources they could use?
All right, I'm going to toot my own horn. Tell your patients to follow me on Instagram because I actually put a lot of education out there. I mean, that sounds horrible to say that, but it is true. There's not good books, to tell you the truth. I mean, there's a couple of ones that are fairly new out that I haven't had the opportunity to read. Have you read any of the newer ones? I'm blanking on some of the titles, but they've only been out in the past year or two.
The Hormone Bible I thought was nice.
I'm sure that half your patients have read them because half of mine have.
I kind of referred a lot of the podcasts of Gabrielle, and then I think is getting a word out there, being the clarity.
She's very conventional, though.
She is, and that's what I was talking about. These people that are, cannibalizing some of the people that got them there in the first place. She went into menopause, and then she's like, "Oh hell, Well, I mean, I've been criticized for 20 years, and I've tried to be my little silo and take the arrows and everything. Like, why are you using this? We have such poor communication as far as numbers. Yeah, you're gonna cause breast cancer. Really, the study showed 8 women out of 10,000 using. Yeah, so that's a 0.08% increased risk. And then they said, well, it's a 26% increase. And it's like a 26% increase of an extremely small number is about extremely small.
Right. There is a Aviva Ram for your patients. Aviva Ram is an herbalist who then went to med school. So she's a physician and an herbalist, and she's got a really good book on hormones, on menopause, and she talks about some hormones. She talks about hormones, but she also talks about day-to-day lifestyle change, diet, herbs, that kind of thing as well. And she's got a very helpful social media presence.
So Beth, I know you do your comment, and then will you give a high level of what's the difference in a progestin and progesterone? And how does that work receptor-wise?
Sure.
Because people always, they say them both. They call them both progesterone.
Makes me crazy.
And they're not both progesterone.
So what I was going to say is with regarding resources, talking about and Marie Claire, she had one of the top shared podcasts of all of 2024, which I find fascinating. So that means there is a hunger out there for information. Women are on the hunt. They want to know what's happening. Social media has helped that conversation. And I think there's, a lot to be learned from the information that is shared in reputable places, even if it is more conventional. At least they get some education, and then that's going to further spark a conversation with their practitioner, which hopefully they will get more educated as those conversations continue to happen.
And then explain the difference in a progestin.
That's going to be the chemical structure. And so they do not have the same chemical structure. So commonly we get asked about, or you hear, just like she said, progesterone commonly interchanged with progestin. So progesterone is going to be your natural bioidentical progesterone that your body produces. Progestin is going to be a chemically altered version of that. And so they do not have the same action when given and inside the body.
Yeah.
So answer your question.
Well, one of my understandings, look at the mic, and you can tell me if I'm wrong, because I've maybe been teaching it wrong for a long time, but one of my understandings is, progesterone will downregulate estrogen receptors, and that's partly how it balances the estrogen.
Yes.
But, and Steve Lane taught me a while back, he used to run pro compounding, progesterone will fit into the slot and downregulate estrogen receptors, but then progestin kind of blocks the spot.
Yes.
Yeah, so it doesn't activate it correctly.
Right.
Correct.
And so people think they're on a progesterone, and it's a progestin or a medroxyprogesterone.
Correct.
So there's just a lot of confusion there, and even as a doc, I didn't know the difference.
Yeah, because so it does not have the same action.
Right.
Yeah.
So it does not have the same action on the receptor. Would
Correct.
be
And then
the answer to that question.
Well, then in the women's health study, like Wendy talked about, they were using medroxyprogesterone or Provera.
Yes.
And
So
they
just
didn't
like
delineate that.
yeah. So just like she said, when you actually dig into that study, it's not surprising what happened.
Yeah. But what's encouraging to me was, even though they used, improper hormones perhaps, the number was still 8 women out of 10,000.
Yeah. Slow.
I was like, well, even using bad hormones, that's encouraging. Yeah.
Right.
And guys, the only reason that they started developing progestins is because they wanted to make a profit, because you can't patent progesterone. And they didn't, for a long time, understand how to make a progesterone that could survive the stomach acid. So Prometrium, which was the first one on the market in the conventional world, they didn't get a patent on the progesterone. They got a patent on the device, the capsule.
That's interesting.
I wanted to open up to you guys for like 7 or 8 minutes, and you guys have all this wealth of knowledge and passion. Why don't you guys ask them some questions? Your hand was first. Go for it.
Can you
routinely check cortisol levels, and if so, like, what's your first go to as far as elevated?
Okay. Question is, do I check cortisol? Yes. On pretty much everybody, because we're all screwed up. I spend my entire day talking about adrenal function, literally. I don't like the word adrenal fatigue because most of us are not there. Most of us are still on overdrive. This is what I say to everybody, because most functional medicine practitioners want to talk about your GI tract, and I do. But if you don't fix someone's cortisol, you're never going to fix their GI tract or their sleep or their hormones or anything. So I have to say this. When I ask people what they do for stress management, 8 times out of 10, they want to tell me about their exercise. That is not stress management. That, if anything, might make it worse. So it's all about a quiet brain and positive emotion on a regular basis. Those two things together will fix your adrenals. Come ask me details later.
Well, and I put up a salivary test if you want to walk through that.
Oh, you want to walk through that? Okay. So this is what I was sort of talking about in that one slide. This is a salivary test. This is an old one from Genova.
Don't get too close.
God, I'm so sorry. Okay. You see how I was saying you peak at, you're supposed to stay low all night long so you can stay asleep. You peak at 9, it drops, it kind of flattens out, and then it drops again. So this person is kind of low but in the normal range first thing in the morning. They're probably getting a little tired around noon because look how low they are. They're wired as all get out at 4 o'clock in the afternoon.
When the kids get home.
Or their husband just got home from work or something like that. And then they can't fall asleep because look how high they are in the evening. Now, I will tell you, for the longest time, I used to order salivary tests on everybody. I had paper charts back in those days, and I actually started drawing just based on what they told me, I started drawing out what I expected the cortisol level to look like. I was right so often that I finally went, why am I asking them to pay for this? So I don't draw it. I'll get a morning cortisol and a morning DHEA, just serum levels, just to get an idea of how long they've been messed up, because you can figure out the phase of adrenal dysfunction that way.
Yeah, that's helpful.
Yeah.
Another few questions. Yeah.
Yeah, Alzheimer's disease and cognitive decline have a predilection for women at about 5 to 1 independent meter read. It's primarily diagnosed based on questionnaires and computerized cognitive tests, not really testing hormones. I would be curious if anyone on the panel has input on with the rates of cognitive decline in this country and Alzheimer's disease, how much is hormone dysregulation playing a role in that?
Let him answer, and then I will make, while they're passing that down, the thing that's interesting is that the questionnaires that they use are verbal. Women do better in general on verbal tests than men do, so they get misdiagnosed.
So it's a great question because it deserves many answers, and it's not one I think we figured out. I think there are some studies that are suggesting that women that have taken hormones have slower progression or don't get Alzheimer's as quickly. That would make sense. You have a higher functioning brain. I think checking ApoE would be a smart thing because you have some of the advanced lipid tests would give a good idea. Your sugar, back to that. It's type 3 diabetes. We're back to, So, I mean, it's a whole picture, but hormones definitely, I think, would be a piece of the puzzle. That would make sense just because of the higher function.
Yeah.
I
mean, estrogen really helps with inflammation in the brain. And it also will help to some extent with blood sugar regulation. Like he says, all of that is important for Alzheimer's. And even if you have ApoE 3-4 or 4-4, it doesn't mean you're going to get Alzheimer's.
Yeah.
I'm a 3-4. I just have to be careful,
Yeah, it's a little higher risk. And if you ever read like The End of Alzheimer's and some of Dale Bredesen's work, it's a lovely book, and I've pitched it to all kinds of patients, and Phyllis got on hormones after she read it because it's so impactful. But he talks about at least 36 factors that promote dementia, and hormones are like 5 of them, but that gives you 31 more. And so they talk about in functional medicine land, like the TAC theory or the leaking roof theory, where if you have 10 leaking holes in your roof and I plug 2 holes, I'm still getting wet. But medicine's like, oh, that plug didn't work. Take out the plug and try again. But instead, you have to look at the whole picture, like plug every hole. So do like neurocognitive retraining, like Michael talked about last month or last quarter. Look at your vitamins, look at your exercise, sleep, inflammation, hormones. So hormones, like Dave said, are a part of it. Let's do a few more questions.
Can I just make one comment? LabCorp and Quest both have a newer test called it's a p-tau. You're looking at phosphorylated tau proteins. And it is a marker that you can use to see if you have a risk for Alzheimer's, kind of where things are, because you don't want phosphorylated tau, so you want to keep it as low as possible. So you can use it to know where your personal risk is or your patient's risk, and you can also then see if your interventions are lowering the phosphorylated tau. It's a brand new test. It's only been available for less than a year.
Yeah, they use it in research, but it's just now available to us.
It's just now, and it's getting paid for.
Nice. Let's do Denise. Sure. Sure.
My mentor did studies on brains of Alzheimer's patients, and 95% of all Alzheimer's brains have spiral symptoms.
So infections, yeah, Lyme, other things.
A lot of times that Lyme and Treponema, there are 41 strains of Lyme bacteria. So we're missing a lot of stuff with neurological disease, and Lyme will not always show up on the IgG and IgA test. You have to do the CD57. Look at from toxins and things, run things off.
Well, and Lyme was another one of those 36,
Yeah.
like infections, another one of those
in
puzzle
general.
pieces.
It's also increased herpes.
Yeah,
Those
yeah,
patients.
HSV. You had a question, ma'am?
Yeah, I just started learning about Dr. Wendy.
TAU.
Fasting like a girl?
Intermittent fasting for a ketogenic diet plus 4 months feasting. And this diet, or any girl from your that you suggest that to address the glucose.
So the question's about fasting.
All right. Here's what I can tell you. In my clinical experience, intermittent fasting does not work in stressed out perimenopausal women.
Sure, because they're already stressed.
Took me. I'm so glad everybody. Yes. She's awesome.
Physiologist.
Lift heavy stuff.
She's done a lot of studies on fast. The problem is most of the settings that were done were med, and then they translate the women just smaller versions of med. So she's done great studies on this, and intermittent fasting does not do as well in women as it does in men. A lot of it's a hormone connection. And she entered, like, I thought I knew what I was talking about, and she, like, took it to another level. So,
Lift heavy.
yeah, lift heavy.
Lift heavy.
Protein.
Yeah, physically, I'd like to chime in with that. I think one of the other big things is stress, and in females and stress. And even in exercise, it's what is the exercise?
Yes.
Because if the exercise is stressful, if it's like HIIT, high level cardio, which a lot of women do for stress relief, they're increasing their inflammation levels, which has been compounding the problem. And so for us on the PT side of things, one of our overarching things is something that we refer to as physiologic downtraining with these patients. And so it's not only just saying like, you need to learn how to relax. It's actually giving them the strategies, showing them deep breathing techniques, mindfulness, meditation, grounding, and appropriate exercise prescription based on their body and where they're at. And then also working on nutrition, because if you're over-exercising and under-eating, there's huge so I mean, it's even just like the basic lifestyle things that I think really intervene on inflammation just as much.
Yeah, and it's never a one size fits all.
No.
That's important. Let's do 2 more questions. Yes, sir.
Yeah, so probably touching on what I was asked about was
Your organ's going off.
Hormone.
You're fine, take your time. I like the ringtone though.
Yeah, cool ringtone.
that's don't get sense. But anyway, just touching on we touched a lot of this
hormones impact sugar down a little tiny bit on stress. But I just know for myself personally, and I live in it, trauma like creates a fire of light that's constant, that can kind of perhaps out your adrenals, but make sure, like that, like getting recent loss, which is also happening a lot more at menopause stage of life. You're gonna have to older, like it's just to do marriages, we think about us, we know it's usual. So, I just sit there, like, when like in your practice, being holistic, of course you gotta go for the physical, it's like you're like a stool, physical, emotional, spiritual, and all those legs have to be addressed. So I just really appreciate what you were saying about not only giving people exercise, that's your inspiration power, you're going to be able to decompress and just keep it agenda. I don't know, like, how can they see a difference? I know for me that when I had and would also very few last year, fight food, like eat fitness or things like that, I would often have a physical very shred. Okay.
Mm-hmm.
Yeah. So personally, at our office, part of this, I think, my partner's husband's a psychologist, which is beneficial to us, but we really feel like the mind-body connection is crucial, and often in our patients that have a really high autonomic dysregulation and stress response, we often do find a trauma component, so we often refer out for mental health, specifically a lot of times EMDR is something that we find to be very beneficial for patients, so we're not just kind of putting a Band-Aid on. We really talk to our patients about physical therapy, intervening from the bottom up, and then, mental therapy and healing trauma, working from the top down. And I would say they definitely go hand in hand.
You're coming on that one?
Guys, the statistics are really clear. Most women, 8 out of 10, have had some kind of abuse in their life, even if it's only the crap I put up with from my male colleagues in med school. I have stories. One of the scariest things that ever happened to me, this was in my conventional practice. I was so proud of my partners that they did this. We had a patient who, for her PhD in sociology, wanted to do a study, and she wanted to ask about trauma. Now, this was the 90s, early 2000s. And so what she asked is if she could put a small, quick little questionnaire that we would have them fill out when they were back in the exam room without their partners. And it would only ask like 5 questions. We spent the next 2 weeks walking into exam rooms with women who were bawling because nobody had ever asked these questions before. I mean, an 80-year-old patient of mine, no one had ever asked her. She had been abused when she was little. So I kind of go into it assuming that everybody's been abused. And it is the one question, well, there's 2 questions on my intake form that get skipped all the time. That one gets skipped a lot because I have a very straightforward question. Have you been, have you had, a couple different questions, and they just, recently or in the past, and they skip it. So just assume, especially if something like that, and they aren't talking about it, they will talk to you as soon as you can get their trust. And, I do see some men, but I mostly work with women. And I mean, men get abused too, but not at the level that we do. The other thing to remember from a sociological and emotional standpoint, perimenopause can be a really difficult time for women because if you have spent your entire life being valued for what you look like, you are shit out of luck. Because that's not how I was raised, and so I was okay. But there's a lot of patients in my practice who hit this time kicking and screaming and trying to still look the same as they did 25 years ago. And my biggest thing with them is to explain to them that that isn't where your value is. And if you're my age, you're talking about exercise. When you were my age, we were raised to say, okay, this is how you stay thin. Do a lot of cardio. You burn off a lot of calories. And then if you're going to do weights, you can do little ones, 10 pounds, and do like 10,000 reps because you don't want to build muscle and get bulky. Well, that just doesn't work.
Yeah, good. one other thing, for people that are interested in sources for their patients for screening for trauma, we use an inventory in our office with all our patients called the CSI, the Central Sensitization Index, and it's a series of, I think it's like 30 questions, and depending on their scores, show their levels of central sensitization, which typically is indicative of trauma, and essentially a high stress response, which then equates to inflammation. And then a book, a resource we give patients a lot, which I would think most of y'all may know, is The Body Keeps the Score. It's a great book. And so those are some great resources. I have an easy read.
No, it's not easy reading, no. Well, and I think too, to walk with people in trauma, you don't need to be a doctor to do that. No. And so our common theme at the Healthy Tennessee Summit, how do we help Tennessee get healthy? Community. You build community. You ask, Dave, how are you? Like, you really get to know people. And so I kind of challenged everybody there, like, you don't need doctors to do that, although we should do that. We don't do that very well, but we should. But everyone in the community can do that. So I just kind of posed to them, like, if you want Tennessee to be healthy, like, we have to do it, not the doctors, like, you guys have to be a part of that. So just caring enough to ask, I find is really helpful. There's a lot of counselors in this room. You could grab Doug, grab some other counselors and ask them, how do you help people navigate trauma and know that they have value, and that their value is not in fear, shame, and guilt, which is the big three, and usually it's a spiral of the three. We should have a session sometime on trauma. Hey, thank you guys. You guys are fantastic. Always really graceful. Here's some things coming up that I just want to keep on y'all's mind that you can think about and pray about, is how do we help our state get healthy? So how do we take what we're doing here as community out back into our communities? And part of the Healthy Tennessee drive is how do we have Healthy Tennessee schools, and Healthy Tennessee businesses, and Healthy Tennessee colleges, Healthy Tennessee addiction, Healthy Tennessee jails? How do we love our whole community? And so I'm excited to see where that goes this year, and I'll keep you up to date with that and find ways that all of us can jump in. But I really value you guys. You guys are great. Our next one's April 28th. Wendy, you're welcome to come back. And that's going to be a Dan O'Rourke talking about underlying cardiovascular disease, underlying causes. So, and this little QR code is just the Facebook. If you're not on the Facebook yet, hop on there, be cool, keep up with us. And I really appreciate y'all coming out and spending your evening. Paul, is there more food? There is. So if you want to take a to-go box for lunch, you are welcome to. I never like to waste food. But thank you guys, have a good night, and we'll see you in April. Love it. And the mics are good? Cool. Oh, Dr. Warner, thanks for joining us. We just had a fun night with the East Tennessee Health Forum and talked about hormones, talked a lot about stress, peppered in some nutrition, peppered in some trauma. It's when you talk hormones, you don't get to just talk about one thing. What would you think, since you've been practicing now 30 years, a little bit more, what are some of the pearls that you would give first to patients and then to providers? Things you've learned over the years that you wish you knew 30 years ago.
For a perimenopausal, menopausal woman?
Just related to hormones.
No, it's related to hormones.
Yeah.
First, menopause is normal. Do not medicalize it, but also don't ignore it. Mm-hmm. And I'm saying that to both patients and providers, because it's been ignored for a really long time, and so women have just been uncomfortable for no reason. And now it's getting tons of attention, but I'm really worried that on some level it might get medicalized the way that puberty has gotten medicalized.
Interesting.
And I think that I want to help these women, but if they don't understand a lot of times how much better they can feel if they handle things like their stress and things like their glucose and keep their muscle mass up so they can keep their insulin stable.
Yeah. Yeah. And so let's say you have a woman, otherwise healthy, typical American woman, say 55, going through the change, less periods more often, maybe hot flashes, cognitive changes. Where might you start with them? They're in your office. Aside from, hey, we should talk about hormones, what are some other big things lifestyle-wise they should be looking at?
Well, everybody in my office gets their stress hormones looked at, their blood sugar and insulin looked at. And I ask them about their day-to-day stress, and I do ask them about trauma. And in terms of, because somebody asked me this earlier, they pulled me aside, what do you do for the person who hasn't actually really skipped that many periods yet? Because but she's miserable because if you start hormones too early, it can actually make people feel worse. Because imagine you happen to make a prescription for her at a point where her hormones are a little low.
Yes.
And it's going to work great until her ovaries kick in. And then she's going to have more estrogen, but probably not ovulate, so probably not make progesterone. So she now is going to be so crazy because she's going to be crazy estrogen dominant.
Yes.
So I will often start with lifestyle and herbs because you can do a whole lot with just herbs.
Yeah, that gentle approach is so nice too.
Yeah.
And you don't have the wide swings of side effects.
Right.
Yeah.
And then, do that for a bit. It also gives her time to start really looking at how she lives her life. And, it's a great time to be able to look up and go, I know I'm busy, but maybe I should actually pay attention to my own health for a change.
Sure. Is there any patient that sticks out to you of, because I see the impact all the time. Rebecca uses hormones all the time. We see it in the office. Can you tell me a recent patient or someone who comes to your mind where hormones really impacted them? Maybe even their whole family?
So we were talking a lot tonight about the lost generation. All those women after WHI that were told, oh no, just tough it out, you'll be fine.
Yeah, hormones are bad. Yep.
Hormones are bad, you can't be on them. This woman has been menopausal for, I want to say about 5 years, fully menopausal for about 5 years, and does all the right stuff. She eats really well, she exercises really well, although I had to convince her to do more strength training and less cardio. She was coming to me initially wanting to just start some herbs or something because she's been told all this time she can't be on hormones. And she happened to have seen some stuff on social media right before her appointment with me. And so I said, so that things are changing with the whole idea of HRT because you haven't been that far from your last period and you don't have any particular risk factors. I started her off really low because she just needs a little nudge. She feels so much better.
Yeah.
It's only been a couple of months and she feels great.
Like herself.
And yes, and she did actually say, oh, by the way, my husband wanted to say thank you.
Yeah, I bet, yes they do. Sometimes I have husbands come in and say, thank you for what you did for my wife. And I'm like, what was it we did again? And usually it's hormones.
Yeah.
Yeah.
And I have a colleague who, she's a nephrologist, and so she always says, hormones are not in my wheelhouse at all. And her partner was perimenopausal, her wife. And she went, I finally convinced her to make an appointment with you. So I don't see her very often. I saw her actually at a conference after I've been working with her wife for a couple of months, and she just comes over, gives me a big hug, and she goes, I was going to hug you anyway, but that's actually for my wife.
Oh, yeah.
Because now I can talk to her again.
Well, and the memory and the brain fog and the depression and the anxiety, and for men too, men will come in and the wives will say, oh, my husband's depressed, he needs something. And I'm like, your husband's not working out, he's tired, his testosterone's in the toilet, his thyroid's off, he's pre-diabetic, he doesn't need Prozac.
No.
And then once you get all that balance, same for women, the whole family is like, our loved one is back.
They're back.
Yes, yeah. And I rarely ever, as long as you're balancing and you're checking labs, I don't see side effects. I'm following them closely, but I think it's very safe.
Oh, yeah.
Rebecca, what are some things that you wanted to ask Dr. Warner?
Oh, I asked her earlier about using progesterone in premenopausal women. And I love how you also just reemphasize that hormones don't cause cancer and went through the new studies on that. That's just so encouraging to hear that.
Yeah. And just for the tape,
yeah.
For women who have some menstrual irregularity, I don't like the term estrogen dominance, but everybody knows what I'm talking about when I say that. When they've got estrogen dominant type symptoms, I tend to start with herbs because it's just easier, like Vitex. But often you do have to add in progesterone instead. And sometimes I'll do the two together because Vitex actually is still working on the prolactin.
Yeah, Chase Perry's nice.
And I think that there is something that we don't see on our current prolactin studies, because I've had people on birth control pills use Vitex for PMS and it worked.
Yeah.
So it had to have been the prolactin. Anyway, And I had been warning you that, and it was funny because you were so glad that I said that you thought you were doing something wrong.
Yeah.
If you give progesterone to some women and they're still really riled up, their adrenals are a mess, they may take some of that progesterone and turn it into cortisol. And they'll feel really good for like the first 2 weeks of progesterone. And then they call you up miserable going, oh, now I don't know what the heck happened, but I'm having hot flashes again and I'm not sleeping. It's because she's not leaving it alone as progesterone and converting it to cortisol instead. So you weren't doing anything wrong. It's just the way some people handle it.
And so what might you do if that's the case? If they start shunting it towards cortisol?
You have to really work on the stress management piece.
Okay.
The hardest
Sleep,
piece.
deep breathing,
Sleep,
supplements, all this
breathing,
stuff.
heart mass. If they're not sleeping, I use a lot of phosphatidylserine
At nighttime?
At nighttime to sort of partially block the cortisol.
Makes sense. And then what if someone's stressed, which everybody's stressed, but I'm talking like they're in your office because they're stressed and their adrenals are off. What kind of exercise do you recommend for them? Just gentle walking or yoga? What kind of exercise to help them get back in balance?
So, I'm starting to talk about it this way. It depends on where you are with your adrenals right that minute. If you are super revved up and you've got a lot of adrenaline that you need to burn off because it is making you crazy, please go run.
Sure.
Please go lift heavy weights. Do something that's going to blow off steam because you need to. But if you're farther along with adrenal dysfunction and you're fatigued all the time and you're not sleeping and all of that, well then obviously don't go exercise like that. Go take a walk, do some gentle yoga, I do qigong, which is
very
lovely,
nice and flowy.
Because it shuts my head up and moves energy in my meridians all at the same time.
That sounds really nice.
It's great.
And so I have one more question. Do you have any questions, Dr. Warner?
Not at the moment, but a ton.
So I asked you in the room, but it's nice to have it on video. For providers, docs, MDs, DOs, PAs, NPs, I guess prescribing providers, what would you say they've never used it before? They were always taught, be careful, it's dangerous, especially in a litigious society. I get all the fear. How might they start wading into the waters of helping their patients, let's just say for menopausal purposes, with these hormones, and where might you start them so they can just get their feet wet?
Well, if they've done any kind of basic training, like with the Institute for Functional Medicine or A4M, that's nice to have that as a background because at least they're conversant. And what I did, and I still recommend this, is try to find a really competent compounding pharmacist that will give you their time. And the way I did it was literally, the person I worked with actually did a whole lecture at a conference decades ago. And I took that information and I started seeing patients and I called her and I said, I'm going to do this and I will compensate you if you need me to. She goes, no, this is good. I would call her up and go, okay, here's what I know about the patient. Here's what her labs show. This is the prescription I want to give her. Tell me how far off I am.
Good.
And it was awesome.
And you start refining.
And within a few months, I kind of had a better idea. And then over the decades, I have, sort of made it my own, and I don't do things the way she initially taught me.
Of course.
But it's a great way to get started.
Yeah, and actually, one of the guys who got me started was Rebecca's dad, who's a pharmacist. And then I'll call up the pharmacy and say, hey, here's what I'm thinking. And they'll say, yeah, maybe bump that up, take that down. Or I'll send them the labs, and they'll give me some suggestions. So it's all about teamwork, because you can't know it all.
Right.
But yeah, but the IFM training was great. I haven't done any A4M, but those guys are brilliant as well. So.
Yeah. The other thing about compounding pharmacists that I've learned over the years is that the patients will sometimes have questions about what turns out to be just the actual compound. Like, I do a lot of buccal troches. And they'll say, I thought you said this was going to be melted in 20 minutes. I said, well, how long is it taking? 45. I say, call the pharmacist, tell them that they're going to change the base that they use.
Perfect.
And they'll give you some tricks. That's the kind of thing that it's not in my wheelhouse.
No, me neither.
Let the pharmacist take care of that.
And is that more progesterone? What's in the troches?
Oh, I put everything in there. Estrogen, progesterone, testosterone, everything.
Because it dissolves, so it's not swallowing.
And you have to make sure you put it up high.
Interesting.
You put it up here so that it doesn't end up being salivary.
Oh, okay. So I've never actually used them, but I see them available. Oh, okay.
Very cool.
So whenever you're not using the topical creams, you just do the troches? That's very, you say troche. How do you say it? I always say troche.
Some people say
I know,
troche,
yeah.
some
Okay.
people say troche. It's
Troche.
a French word. I don't
So we're all
speak
saying it
French.
wrong is what you're
We're
saying.
all saying it wrong.
I'm going to Google that tonight and see how to say it. Hey, thanks. You drove all the way from Pennsylvania. You're our farthest driving speaker.
Oh, it's only 8.5 hours, no big deal.
8.5 hours, I know. But appreciate your time. And I think everybody else learned and had a good time too.
You have got a great group here.
Hopefully it keeps growing.
Yeah. Good luck to you.
Absolutely. So thanks for joining
Thank you
us.
so much.
And that's Dr. Warner with IFM, and her practice is in Langhorne, Pennsylvania.
Yeah.
So thanks, guys. How'd it sound? Well, guys, that's a wrap. We had a fantastic night hearing from Dr. Warner on bioidentical hormone replacement. The panel discussion is always great. And, you know, we had a discussion around the roundtables of, now that we've had the East Tennessee Health Forum going for a year, how can we really drive health into our community by driving connectivity, community ideas, knowing who can support us in the community. So when I have a question about hormones, I know a couple of docs I can go talk to and refer patients to. Or if someone's looking for help with, you know, pelvic floor physical therapy, I know who I can refer them to. And so it was a great night. Really glad you guys joined us. Feel free to come in person next time. We meet every quarter. Our next dinner is April, I want to say the 17th, but it'll be on the website. But we meet in April, August, and then November. So again, roughly every 3 months. So glad you guys joined us, and we'll see you soon.